All right. Well, again, welcome everyone to our June Town Hall. And I know most of you enjoyed a wonderful weekend. I saw many of you posting over your adventures over the past number of days. And welcome to our first of, I guess, our summer town halls. And with that, we're taking a different approach with the next couple of programs. So tonight is actually part one of a two-part program, and looking at biostatistics. And I think, for any of us, no matter how long we've been practicing, whether we just graduated or we are a seasoned veteran, it is always good to review statistics. They're still important to us, but we may have forgotten the ins and outs of how to address these issues when we need them. So we're very pleased tonight to have Dr. Charlotte Bulch with us. She is the biostatistician, excuse me, I know it's going to get caught on that word, and adjunct assistant professor at Midwestern University, Glendale. So the sister campus of our Downers Grove campus here in Chicago. So I will turn it over to Dr. Bulch.
Okay. Can you all see my screen?
Yes, we can.
Okay. Perfect. Great. So welcome, everybody. I'm really excited to talk to you. So this is going to be a talk about biostatistics for the practicing pharmacist, part one. So I do not have any conflicts of interest or disclosures. So the objectives of this talk are going to be to explain some basic biostatistical measures and also explain some basic epidemiology measures that I'm seeing coming up in certain types of vaccine trials and articles that we'll be looking at. And then finally, we're going to end with identifying and describing the concept of variability, focusing on sampling variability and confidence intervals. So before we get started about kind of talking about those terms and reviewing those terms and what they mean, I want to give you a broad overview of statistics and what we use it for. So statistics is our, kind of in our first step of statistics is to identify a population. A population is the entire overall group we are interested in studying, and the populations are usually large, but can also be small sometimes. And generally, the population is so large that there's no way we can study all of it. So examples of populations might be all pharmacy students in the US or all adult males in Chicago. So instead of looking at the entire population, what we do is take a sample of the population. So step two, we want to choose a sample that will represent the population well. For example, if we were to study all male adults in Chicago and how much time they spend on their phones, we would not want to just select a sample of all males under 25 years old or a sample of males living in a certain area of Chicago. We would want to make sure that our sample is a random selection from the population. So after we've defined the population and taken a random sample, the rest of the investigative process of statistics is based on collecting data from the sample to answer a specific statistical research question, and then exploring the data using descriptive statistics and graphs and visualizations, and then using inference to draw conclusions about the population based on the data collected in the sample. So there are two parts of the fields of statistics, as I mentioned before. So we have descriptive statistics and then also inferential statistics. So descriptive statistics involve describing a data set in terms of summarizing, organizing, and simplifying the data. Descriptive statistics might involve summary measures, tables, or graphs. And then we generalize the information from a sample to a population. We are performing inferential statistics. And these sorts of generalizations are called inferences and include analyses such as t-tests, ANOVA, and confidence intervals. We're going to focus on, in this town hall, descriptive statistics and talking about confidence intervals from inferential statistics. And then next month, we're going to go more in depth about tests used in inferential statistics. So just a few terms that we need to go over before talking about descriptive statistics. First is a parameter. So a parameter is a numeric characteristic pertaining to a population. And then a statistic is any number you calculate using data. And so we use statistics to estimate the parameters. from the population. So the statistic is just an estimate. We are never going to know the true parameter value unless we are able to measure the entire population, which is really hard to do. So when you're thinking about a population, we're talking about parameters. And when we're talking about a sample, we're talking about statistics. So next, we're going to go into a few summary measures and describing what they are and how we're seeing them in articles. So how do you describe data? So we usually use descriptive statistics to describe our data based on the type of data we have collected from the sample. So the focus on quantitative data is using descriptive and inferential statistics. However, I just want to point out that qualitative data can be just as informative, but usually for a different type of research question, focusing on maybe an individual's perception or experience. So this is a flow chart of the different types of data that we can collect from a sample. And we're going to be focusing on this session on quantitative data, which is usually broken down into discrete data, sometimes called categorical, and continuous data. For discrete data, we have binary 0-1 variables, nominal data, which is like various categories like race, and then ordinal data, which is there's an order to the category that's normally seen in Likert scale responses, so strongly disagree to strongly agree. And then for continuous data, we have interval and ratio data. So for summarizing the measures from quantitative data, we're first going to look at continuous data. So the center of the sample data is usually described by using summary statistics like the mean and the median. So the mean is the average value from the sample, and the median is just that middle value from an ordered sample. And the mean is very sensitive to outliers, but the median is more resistant. However, we don't just want to know where the center of the sample data is. We also want to know about how far spread out the data is and how much variability there is. So for the mean, you usually report the standard deviation, which quantifies how far the observations are from the mean. It can be thought of as like an average distance that a group of points lie from the group mean. So a large standard deviation means the sample data is highly dispersed. For the median, however, we usually report the interquartile range. So each set of continuous values can be broken down into 4 quarters. So the median kind of breaks the data into 2 halves, and then the bottom half, we can, the quartile 1 separates the lower 25% of the data, and then quartile 3 separates the lower 75% of the data. So the interquartile range is just this quartile 3 minus quartile 1, which represents the spread of the values 1/4 above and below the median. And then we can sometimes also report the range as well for both the mean and the median as well. And then for discrete data, we usually report the number of participants in each category and also the percentage as well. So we're going to first take a look at the summary statistics reported in an article about the Pfizer vaccine trial. And so as you can see here, the summary statistics are normally reported in table 1 about the demographics. And you can see here that they report the median age and also the IQR, which makes sense. And they're reporting the median age of 45 years for their unvaccinated controls and 45 as well for the vaccinated persons, and then they're also reporting that IQR, so the quartile 1 and quartile 3. And then for their age group, they also broke it down into categories, and they're also reporting the number and percent within each of those categories. We see kind of a different set of summary statistics in an article from the Johnson & Johnson vaccine trial. So they're reporting sex in terms of categories, in terms of number and percentage, but then for their age, instead of reporting median and IQR, they're reporting the mean and the range, and then they're also reporting that standard deviation as well. So next, we're going to go into some epidemiological / biostatistical terms that are seen without kind of through these vaccine articles and also other kind of clinical trial articles as well. So first, we're going to talk about incidence. So incidence is the proportion of new cases of a disease during a specified time period. And an example of this might be 20 of 130 people that attended a picnic developed diarrhea in the next 24 hours, which is not good. And then we have prevalence, which is the proportion of existing cases of a disease during a specified time period, which might be that there are 20% of patients with influenza reported by Maricopa County in March 2010. So just to remember that incidence is used to describe how many people were diagnosed with a particular disease or condition in a particular population of people studied. And then prevalence tells us how many people have a particular disease, regardless of whether or not they were just diagnosed or even whether they have been diagnosed at all. Another descriptive statistic used to describe events occurring in a sample are odds. So we usually want to calculate odds because we want to know the probability of the event occurring. So odds are the probability of an event to occur divided by the probability of an event not occurring. So let's look at an example. So we have a study that looked at suicidal adolescents, and 186 of those adolescents did not exhibit suicidal behavior at 6 months of follow-up. And of this group, 86 of those people were assessed as having depression. And then we have 77 young people that have persistent suicidal behavior at follow-up, and 45 were assessed as having depression. And so for this example, we can consider the cases as adolescents that have persistent suicidal behavior at follow-up, and exposure is assessed as having depression or not. So we can calculate the odds of cases. We have the number of adolescents that have persistent suicidal behavior and depression divided by the number of adolescents that have persistent suicidal behavior but no depression. So that is going to be 45 divided by 32, which is just 77 minus 45, which is going to equal 1.406. And next, we can calculate the odds of non-cases. So the number of adolescents that did not exhibit suicidal behavior at follow-up, that had depression, divided by the number of adolescents that didn't have suicidal behavior at follow-up and had no depression. So that's going to be 86 divided by 100, which is just 186 minus 86 for the denominator, which equals 0.86. However, these odds are sometimes really kind of hard to wrap your mind around and really understand what's going on. So we usually talk about the two odds. We just calculate it on the slide as an odds ratio rather than these two separate odds values. So an odds ratio is a measure of the strength of the association between exposures and outcomes. And so it's a comparison of odds in two different groups. So an odds ratio of 1 means the exposure does not affect the odds of outcome. And then an odds ratio greater than 1 means that the outcome is more likely in the exposed group. So the higher the number, the stronger the association. An odds ratio of less than 1 is not as common, and it means there is a protective effect. So we can actually calculate the odds ratio from the previous slide. So we take the odds of cases divided by the odds of non-cases. And so from the previous example, that's 45 divided by 32 over the 86 divided by 100, which equals 1.63. And so we interpret this usually when we're talking about an odds ratio as the odds of persistent suicidal behavior is 1.63 times higher given baseline depression diagnosis compared to no baseline depression. So in some studies, we don't necessarily report the odds ratio, we need to report a risk ratio or relative risk. And so this descriptive statistic is a measure of the strength of association between exposures and outcomes as well. So it's similar to the odds ratio. And the relative risk is the probability of an event occurring in a treatment group versus the placebo group. So in terms of the calculation, we take the number of people with the outcome or disease in the treatment or an exposure group divided by the total number in the treatment or exposure group in the numerator. And then in the denominator, we have the number of people with the outcome of the disease in the placebo or non-exposure group divided by the total number in the non-exposure or placebo group. And we usually sometimes calculate this as a ratio, and then sometimes it's converted to a percentage for interpretation. So let's look at an example. We have a study of over 22,000 male physicians, and they were randomly assigned to take either low-dose aspirin or a placebo, and they were followed up for 5 years to see whether they had a myocardial infarction or not. So we can calculate this relative risk by first taking the number of physicians that took aspirin that had an MI divided by the total number of people that were in that aspirin group. So that's the numerator, and then on the denominator, we take the number of people in the placebo group that had an MI divided by the total number of people in the placebo group. And we get this relative risk ratio of 0.58. So thinking back to that odds ratio slide, I said that a value less than 1 means that there's a protective effect. And so we can use that same type of interpretation for relative risk. However, in order to interpret the risk ratio less than 1, it's pretty confusing to interpret it as 0.58 times greater. So we usually end up taking this inverse. So we go 1 over the relative risk and get a value of 1.72. So we can interpret this as the people who took the placebo treatment had 1.72 times greater risk of having an MI than people who took aspirin. So odds ratios and risk ratios are similar, but they represent different values and are used to report descriptive measures for different types of studies. So for risk ratio or relative risk, you need to know the people at risk. So that is why the statistic is usually calculated for prospective studies, such as cohort studies or randomized clinical trials. The odds ratios are normally calculated for retrospective studies, such as case control studies. And for rare diseases, however, the relative risk and odds ratio are very nearly the same. So next, we're going to briefly go over efficacy, in particular vaccine efficacy and vaccine effectiveness. So this is a measure of the proportionate reduction in cases among vaccinated persons. And you've seen this as very common being reported throughout the media and has been a common outcome reported in a lot of the vaccine trials. And so efficacy can only be reported though under ideal conditions like clinical trials. And so the way that you calculate vaccine effectiveness is you look at the risk among the unvaccinated group minus the risk among the vaccinated group divided by the risk among the unvaccinated group. And so you can see that we're talking about risk, and if we refer back to our previous slide, calculating relative risk, we can actually calculate the vaccine effectiveness by just taking 1 minus our relative risk calculation. So we're going to briefly look at an article about the Pfizer vaccine again, and we can see that they're using a lot of those terms that we just talked about in their article. So we can see the number of people at risk, which can be calculated since this was a prospective study, specifically a randomized clinical trial. So they're reporting the number of vaccinated and unvaccinated people at risk at each of these time points in this first table. And then they're reporting the cumulative number of events at each of those time points as well. So then in table 2, this is normally the table where they're talking about the vaccine effectiveness. So we can see that they are reporting this as 1 minus the relative risk. And we can see that the vaccine effectiveness for 14 to 20 days after the first dose for this documented infection is 46%. And then we see that slowly climb to be 92% for 7 days after the second dose to the end of follow-up. And so they're also talking about these vaccine effectiveness actually within the article as well. You can see the 46% as right here, but then they're also reporting this confidence interval. And so the next part of this talk we're going to go into is talking about what is the confidence interval and what does that mean. So in order to talk about confidence intervals, we also need to understand variability. So we're going to go over sampling variability, sampling distributions, and then bring it all together with confidence intervals. So this is just a funny cartoon that I like to talk about variability. So there's a lot of people drowning in the water and they having to be rescued. So, and the comment says, with only a limited number of helicopters, search and rescue had to randomly sample from a pool of subjects. So in understanding variability, we really need to think about data in terms of distributions. And so we distinguish between the different ways distributions are used to describe variability in a population, in a sample, and in the values of a statistic. And these are all key to developing this idea of statistical inference. So there are three types of variability: variability in a population, variability in a sample, and then sample-to-sample variability. And so we have a population, and then we have a sample, and from that sample, we calculate a statistic. There's variability in the population, there's variability here in the sample, and then the statistic is just a single number. We can also have a population and then sample multiple times. And so we get multiple statistics, and there's variability in each of these statistics. So the variability in a population, we describe by a population distribution. Variability in a sample, we describe with the sample distribution. And then sample-to-sample variability, we talk about as a sampling distribution. And so it's important to understand that the sampling distribution is the distribution that results from taking these multiple samples, which is different than a sample distribution. So we're going to go over an example using a proportion that was reported from the American Heart Association from the National Health and Nutrition Examination Survey. And it said that from 2007 to 2010, adults with high blood pressure, about 75% of them are under current treatment. And so we have a claim about the proportion of adults in the population. In our population is adults with high blood pressure. And let's say we take a sample of 100 adults with high blood pressure and find that 70 of those adults are under current treatment. So we're interested in what are the likely and unlikely values of this sample proportion for samples of size 100 if the population proportion is 0.75. So an interesting way to start looking at this idea of sampling variability is to use a pretty cool applet. So here on the screen, I have the population proportion of 0.75, and then I have a sample size of 100. And so right here we see this is the population distribution, and we have our proportion right here. So I'm going to take one sample and draw one sample of size 100. And what I end up getting is I get a sample proportion that is drawn from that population to be 0.77. And we see this orange dot is the population proportion, and then this is our sample proportion in the blue triangle. And so this value then gets put down here in our sampling distribution. And so next we can see, we can draw 5 samples of size 100. And so we can start seeing down here that we're starting to see different sample proportions for each sample drawn. And we're starting to see this variability in the sample to sample proportions. Finally, we can draw 100 samples of size 100. And so after drawing these 100 samples of size 100, we're starting to see this sampling distribution starting to form of the population proportion. And we see that the mean of the sampling distribution is 0.746, and the standard deviation is 0.426. And we start to see that this mean of the sampling distribution is starting to look like our population distribution. So the sampling distribution describes this long-run behavior of a sample statistic, and it captures the sample-to-sample variability. And so the distributions we're looking at are approximate sampling distributions for samples from a population with a population proportion of 0.75. And they're generated by taking many different random samples from the population. However, we don't always know what the mean or proportion of the population is, and we don't know the standard deviation of the population. So we have to use inference. And so one way we use inference in terms of making generalizations from the sample to the population is by using confidence intervals. So we can calculate a confidence interval for the proportion, but also for the mean as well, because that same idea of a sampling distribution applies for the mean as well. So p hat is our sample proportion and x bar is our sample mean. And so since we're wanting to calculate an interval for our confidence interval, we need to account for the variability in the sample statistic. So we don't know the population standard deviation usually. We can use the sample standard deviation and estimate the standard error, which provides us a measure of variability of this sampling distribution. So this is the standard error for the mean, and then the standard error for the proportion. And then finally, we have these Z star and T star values, and those are the number of standard deviations away from the sample mean based on the level of confidence we want, which is usually about 95%. So this is how confidence intervals are calculated, but what's more interesting is what does this confidence interval mean and how do we interpret it? So the value of the parameter, usually the population proportion in this case, is fixed. It's just unknown. There's not a probability of the value, just a probability of whether our interval contains the value or not. So we are interested in what is the confidence interval for 73% of adults with high blood pressure in our sample that are under current treatment. So this image from another applet simulates and showing us the confidence intervals for 100 samples of size 100. So these green confidence intervals show the intervals that do contain the true population proportion, while the red confidence intervals show the intervals that do not contain that population proportion. So this shows us that confidence intervals vary, but can contain the true population proportion or mean. And this is what we mean when we say we have a 95% confidence interval. We're sampling from the population over and over again, and 95% of those intervals will contain the true population proportion or mean. And we can see from the simulation that we're very close. We have 96 intervals that cover, but 4 that don't. And so when we're interpreting a confidence interval, we usually use 95%, but we can also use 90% or 99% sometimes. And there's 2 interpretations here on the slide. So we can kind of interpret that confidence interval as we are 95% confident that the proportion of adults with high blood pressure under current treatment is covered by the interval 0.643 to 0.817. However, we cannot say that there's a 95% chance that the true proportion of adults with high blood pressure under current treatment lies between 0.643 and 0.817. So remember, the value of this parameter, the population proportion, is fixed. It's just unknown. And so the confidence interval is not the probability of the value, just a probability of whether our interval contains the value. And so to wrap up, I wanted to show you again that confidence intervals are also reported a lot in the vaccine trial studies. So this is the abstract from the Pfizer vaccine trial. And so, for example, in this abstract, we see the following sentence. The estimated effectiveness in preventing death from COVID-19 was 72% for days 14 to 20 after the first dose, with a 95% confidence interval from 19 to 100. So this is a fairly large confidence interval with lots of variation in the vaccine effectiveness at that time point, but it is based on the vaccine effectiveness after that first dose. We can also look at the vaccine effectiveness documented for infection at 7 days following the second dose with 94%, and the confidence interval can be interpreted as we are 95% confident that the effectiveness of the vaccine in infection is between 87% and 98%. After that second dose, which is very good. So that concludes my talk, and I'm happy to take any questions, and then we can go into the post-test questions. questions as well.
Does anyone have any questions? Remember, you can raise your hand and we can unmute your line, or you can place your questions in the chat. Oh, Laura, go right ahead.
Hey, thank you, Dr. Bulch. This was mind-blowing because I had forgotten a lot of it. So thank you for the much needed refresher. So for example, this confidence interval, so the COVID-19 was 72% effective with a 95% confidence interval, 19 to 100. The 19 to 100 is the percent effectiveness that they found in the sample.
Yeah, so they're yeah, it's kind of talking about there's so much variation in the sample that they were seeing that's why that confidence interval is so large. Yeah. So that's why it's kind of 19 to 100, because they're seeing so many kind of different effectiveness of the vaccine in that sample.
Okay, got it. Thank you. Okay. I still got some brain cells left in there. On that note, isn't that I mean, this is subjective, like 19 to 100, that seems like clinically a large number to me and kind of a red flag. Is that right?
Yeah, so I think it's, you also have to take into account that it was just that, you know, that first dose and that certain time point, and you do kind of see the confidence intervals getting closer and closer. That's why I kind of pointed out the one at the end, because it's less, but you also see there's a lot of other factors. So what they were trying to have, you know, they're doing randomized clinical trials, so they're controlling for all these different variables too, but the variation, you know, might be due to something that they weren't able to control too. They just didn't know about that, or they're trying, you know, more studies now, but they're trying to control as much as possible in the randomized clinical trial. But yeah, it's just kind of interesting to see how wide those confidence intervals are, and you're like, oh, that's not necessarily that great, but they're good to report them, because it's good to just show that there was a lot of variability in their sample, but it also might be due to the fact that they had, you know, lots of different people with different types of kind of like comorbidities and stuff. So I didn't show all the demographics, but that also might be the case too. So, but it's good to kind of indicate with those confidence intervals that there is that variability in the sample. And it's not just, you know, it's trying to get people to not think about the fact that, oh, when I get the vaccine after that first dose, I'm like automatically, what it was, like 72% effective. It's like, that might not be true. So that's kind of why the confidence interval is important to report, because you're trying to get people to not understand that it's just one single value.
Any other questions? Dennis, go ahead.
I think you're muted, Dennis.
Dennis, if you can go ahead and unmute. I've got it. I'm asking you to unmute on your side.
Just to dumb this down for the public. My understanding is there's about 330 million people in this country. Is that correct?
I think so. I don't know off the top of my head, but yeah.
And how big are the populations of the people that are involved in these tests?
I have to go back and look.
I mean, approximately. I don't need to.
Yeah, I think so. This study group, at least for the Pfizer, was 596,000 or so.
I mean, do you see where people get confused? It's like, we've got this many people and the sample size is only this big. And it's like, how does it instill credibility
right
to get the vaccination?
Right. Yeah, no, exactly. And I think that's the kind of hard part, is it's that idea of taking a sample and being able to generalize that back to the population. It's like the statistics are there, and we have the statistics for that. but I definitely agree. It's hard for people to understand that, you don't have to study the entire population in order to understand the effectiveness of the vaccine.
So I guess my point is that to try and get the population to get involved in the vaccination, now we've got what, 50% of the country now we have to get involved in this. And obviously you can see why there's a lot of pushback on their end, because
Right.
I don't know, I mean, that's what we got to work on. That's our target goal, is to try and find a way to convince them that it's good, but how do you do it?
Right. Yeah. No, it's not easy.
Okay.
It's-
Thank you.
Hank, you have your hand raised. Go right ahead.
This reminds me of back a time years ago when I was the lead pharmacist on a nationwide study, and our pulmonologists were pulling patients into this study with such enthusiasm that they shut our site down, because they were the people running the tests were afraid we were going to skew the data with so many participants coming out of one institution.
Oh no. I'm sorry to hear that. Yeah, it's you want to get people involved in terms of the sample, but yeah, it also creates, if you get too many people, it kind of creates you're not able to kind of keep that kind of sampling as it should be. So.
Any other questions or comments? All right. Well, thank you, Dr. Bulch, and I greatly appreciate you taking time to go through part one with us this evening. I think you do have some post-test questions. Is that correct?
Yes. Yes. Would you like me to go through those?
Yes,
now?
go right ahead.
Okay. So the first post-test question is, which of the following measures can be used for interval data? The mean, mode, standard deviation, or all of the above?
Remember, everyone, you can put A, B, C, or D into the chat. You guys are being really shy tonight.
I just can't remember if it's. That
So
does
even
sound. That sounds
so-
right, that A and B go together, and that C is different. I
So
think.
when talking about interval data, we're talking about those continuous data. We didn't specifically talk about the mode this tonight, but it is a measure of how common the values are. But the mean does go with the standard deviation, and you can also talk about the mode or the median as well. So the correct answer is D, so all of the above. So they're all terms of summary measures. Okay, so the next is the following statement true or false? The odds ratio describes the odds that an outcome will occur given a particular exposure compared to the odds of the outcome occurring in the absence of that exposure. True or false?
That's true, I think.
Yes.
Yes, because yes. Only because you're nodding yes. So I will go with a confident true.
Yes, that is true. So the odds ratio does compare the odds in the two different groups, odds of cases divided by the odds of non-cases, given the exposure and non-exposure. Okay, so the third one is, so suppose a 95% confidence interval for the proportion of US adults who smoke is 0.11 and to 0.16. So is the following statement correct or incorrect interpretation of that confidence interval? there is a 95% chance that the true proportion of all US adults who smoke is between 11% and 16%. I'm seeing Ben's answers, B and David. Yeah, so that is incorrect. So remember, the true proportion and the numbers in our interval are fixed. So the probability is either 1 or 0, depending on whether the interval is one of the 95% that cover the true proportion or the one of the 5% that do not. So that's an incorrect interpretation. And then finally, we have the same confidence interval in the following interpretation. Is it correct or incorrect? Based upon our sample, the true proportion of US adults who smoke is estimated to be 13.5%. With 95% confidence, this value could be as small as 11% or as large as 16%. I'm seeing A and yes, that's correct. So this is correct. It's an actually more thorough interpretation as we include both the point estimate and the confidence interval. And so some journals will state this, something similar to this statement. So great job. So just a few takeaway points. You learned how to explain summary statistics and measures of association and understanding the difference between variability, the sample and sample to sample variability, and then how to interpret a confidence interval. So I have some resources, and then thank you very much. And I look forward to talking to you more next time, and we'll learn more about statistical tests.
Thank you again, Dr. Bulch. Any final questions for her before we let her go? And we'll speak to her again in July. All right. Well, thank you very much. Have a great rest of your evening.
Thank you. Thank you so much, everyone.
And I did place the evaluation link into the chat. I'll place it again here. I know we did have a couple that were just on the phone. So remember, it's I want to pause the recording here so we can talk about code. All right, everyone. I do want to kind of go through the rest of our information this evening. And let me get this positioned. So I want to take a different approach on our national statistics for this evening. As you can see, there are 33 million cases, but this is talking about distribution of the vaccine. And so we've had just under 300 million doses distributed through the United States. And this data is a little behind because it said Illinois had 11 million doses. It's a little bit higher than that. We'll see that on the state statistics here pretty soon. But I do want to kind of start shifting the approach towards recovery instead of focusing on the case numbers. This is the best I've seen the state in a long time whenever we look at the number of cases. If you've been following the state statistics, and those of you who are signed up on Siren, and all of you should be signed up on Siren, you get the daily reports, and we've been under 500 now for a couple of days and well over 1,000 now for almost a week. And it's great to seeing the test positivity close to 1. The closer to 1 is what we want to get for our state goal. We've had 13.7 million doses that have been distributed, and about 11 million of those have been administered. So that's not too bad, about 41,000 vaccinations a day, which still isn't too bad. And you can see the split, and I think you will start seeing a huge shift here. Most of this inventory has been with local health departments, but more and more has been shifting over to community partners, which includes pharmacies. I think you will see that shifting very rapidly in more towards the community partners. Those of you who are local know that Saginaw County announced today that they're actually going to be rolling back and shutting down their mass vaccination unit because of just lack of response from the community, which is not good, but that means that they're going to be depending on the community partners to be taking this up going forward. And this is where we come in. So we got to make sure that we're engaging our patients, and every patient asking about whether they have they've been vaccinated, and especially if you have supply, you can get them vaccinated. This is the distribution throughout the state. So right now we've got just under half of the state is fully vaccinated at 5.2, just almost 5.3 million. So we're still a long way. I know that there's some incentives now from the federal government of trying to get states to 70%, but we know we're going to have at least in Illinois, we're going to have a long way to go on that. And if we do get up to 70, it's going to be a very skewed distribution. You're going to see looking at Chicago and some of the metro areas are going to be where we're going to have the highest incidence of vaccination, where in the central and the southern part of the state, it's going to be really rough. And so it's something that we have to continue to work on. One thing I know that we need to make sure that we're discussing and reinforcing is that there is no out-of-pocket cost to patients. I saw yet another article today that especially in Hispanic and Black populations, there is a presumption that there is a cost, that their insurance is not going to cover everything. And we need to make sure that everyone understands, regardless of your insurance status or if you have insurance, you're covered. So we need to make sure that we're reinforcing that with them. And everybody, we didn't think we'd get here this soon, but Illinois, if everything holds, should be open. The state should be reopened on June 11th. And I put maybe Chicago too, because the mayor has not stated that they are going to reopen on the 11th just yet. But they didn't want to commit to a date, but we're almost there. I did not think that we would be at phase 5 this early. So this is really great to think that, just less than a year and a half ago, we were in complete lockdown to now we're back at phase 5. So this is a really great, and it's all to a lot of the work of of everyone on this call and all of our peers and healthcare of really doing our jobs and getting vaccine out. But we got to continue to push because we're long from being done. I want to spend the rest of our time this evening talking about legislation. Just to kind of give you, we got through our normal whirlwind of a legislative session. We've had just over 7,000 bills that were introduced. Remember, this is the first year of a 2-year cycle of the General Assembly. So you can see the House was definitely throwing out more bills than the Senate. And there were about 700 resolutions, which resolutions can have impact on policy. When we were looking at legislation for this year, we were focusing on 2 major priorities for IPHA. One was PBM reform, and the other one was our contraceptive access bill, which also advances provider status for payment and recognition of pharmacists for patient care services. So if the PBM bill, because it is a massive undertaking and that bill has a lot of major components, we're going to be in summer negotiations on that bill, and we're going to be looking at trying to bring that back around pretty quick so we can continue to move forward with our legislative agenda. And so you still see there, we did not get it out of the Senate Insurance Committee. Now, House Bill 135, you see where it is right now. It's sent to the governor. It's passed both houses. This has been a long effort. We've been working on this bill for almost 5 years. And it's really great to see that we finally got to a point where we're going to have a way that we can start building upon this one, because it'll allow us to start adding additional services and recognition on this legislation once it's in place. So We really should be very proud of a lot of the work that not only IPHA has done, but other organizations, and working with the obstetricians and with the Med Society and with ACLU of Illinois and Planned Parenthood of Illinois. If it wasn't for a lot of these groups, this bill would not have passed. And so it's a lot of hard work and a lot of negotiations over the last number of years. And I really have to give Representative Mussman and Senator Bush a lot of credit. Representative Mussman, you know, she's been in there, was compromising and negotiating on these conversations with everyone for the last number of years. And if you ever really want to hear about someone fighting for pharmacy, go back into the debates of House Bill 135 on the House and in the Senate floor, and listening to these two champion for pharmacy. And it was really good to hear legislators standing up for us. Like I said, House Bill 135, which was a priority bill for the association, has gone to the governor's desk, and it, you know, establishes a pathway for us to be recognized or remunerated for those patient care services, not only commercial insurance, but also Medicaid. That's the one thing I want everyone to kind of set and let that kind of settle in your brain for a bit. We can finally get paid beyond just cash for the services we are providing. Now, granted, it's in the realm of contraceptive services for the moment, but this allows us to have a mechanism of moving forward. House Bill 119, this passed out of the House and went to the governor's desk. This creates the Illinois Drug Reuse Opportunity Program Act, or the iDrop program. We did talk about this at Legislative Day. This bill would allow for medications that are no longer needed to be used by the patient, whether by discontinuation or their passing. The medication, if it is still within date and is in unopened packages, can be returned. And there will be programs set in place through Department of Public Health about how pharmacies can receive the medication, and how patients can return the medication into the program, and how this medication can then be redistributed. So this will, again, was being modeled after Iowa. So we'll see how this works out in implementation over the next 18 to 24 months, because this will be one that'll take a little bit to get going. Senate Bill 2172, this was an IPHA initiative of being able to help move the accreditation training date from January of 22 to January of 24. Both IPHA and ICHP have been talking with the department over the last year that even though this went into effect in 1/1 of 20, we were trying to set up, you know, mirroring standards that PTCB had put in place for applicants that want to become certified technicians, that they have to go through an ACPE ASHP accredited program or have equivalent training. And the equivalent training, according to PTCB, is a documentation of 500 hours. We want to continue to work on that with the department. But the major reason we looked at delaying this initiative requirement into the act was we went from about 15 educational institutions offering this into the state to 2. And so we've got about 3 that are going to be coming up online, hopefully in the next year. So we're wanting to make sure, as we start to continue to help establish a pathway for our technicians, that we need to be starting at a career path for them. And so this also allows why we need to make sure we're having additional accreditation, because we're asking them to do a lot more. Think about what we've done over the last year. We've, in addition to what Illinois had already done, stepping forward and giving technicians the right to be able to administer, it was also recognized by the federal government. So we need to make sure that we're preparing our technicians appropriately for the new tasks that we're going to be doing. And especially if we're going to be taking on more consults, especially in women's health and other areas, and we're doing more telehealth, we need to be having technicians assisting us with these activities, and they need to be properly trained. So this gives us some couple years of wiggle room, so we can work with the department to flesh out these requirements, or work with national partners to have a better conversation about what we need to do at this point for training. House Bill 711 and House Bill 1745 were both initiatives of Majority Leader Greg Harris, and he put through a massive prior authorization reform package and a co-payment and out-of-pocket reform package. And these are really going to be helping with patient access to medications, eroding a lot of the barriers from the PBMs for patients' access to medications, but also trying to help limit their out-of-pocket expense. So we'll see over the next couple of years as these are fully implemented and the rules are put into place, how well these do impact change. We've had prior authorization reforms before, but it's got to come down to the Department of Insurance doing their job. And that really comes back to us being advocates back for our patients when the Department of Insurance is falling flat, which they have historically done many, many times. House Bill 279 did pass. This was an initiative of Representative Carroll. And this is one, he has family members who have gluten allergies, and this is a personal initiative for him that he feels that manufacturers should label if any ingredients in a medication have gluten in it, that it should be well identified. We worked with him to amend this so that, because the penalty for this is to be considered to be misbranding. We worked with him so that this would only impact manufacturers and would not impact pharmacies or pharmacists. And so he understood that it's too much for, we don't have any impact on that, and he fully understood that. House Bill 3497, this was an initiative that IPHA worked with IRMA, and it was an initiative of ICHP, and we are glad to work with them on this to help expand the Board of Pharmacy. And this would be starting of a modification of the Board of Pharmacy and taking a look at putting into the act, making sure that specific practices are identified and represented. And in this case, having an inpatient health system pharmacist, there have been many unwritten rules to this in the past, where you would have a community pharmacist or an independent pharmacist, an employee pharmacist, a long-term care pharmacist, a health system pharmacist, etc. And that has not been upheld over the years. And we know that since these individuals on the board not only are there to help with helping give guidance and advice on policy, but they are also there on giving out and overseeing disciplinary cases. And it is hard to be able to provide proper oversight if you do not know that practice segment. And so we need to make sure we have members of the board that are on the Board of Pharmacy that do represent the diversity of our practice settings in the state. And in addition, this also would put on a pharmacy technician, because technicians are also disciplined by the board, but they are also the largest segment of those that are regulated and oversaw by the Board of Pharmacy, and they should have a voice on the board. And because if you look at it, it's almost 2 to 1. There's about 36,000 technicians and about 14,000 pharmacists that are licensed under the board. So let's talk about the budget. Remember, the budget is not the budget's not a simple process, and that's a statement amongst itself. But really, the budget is 3 separate components: the capital reappropriations segment and what's called the BIMP, or the Budget Implementation Act. And so usually this is 3 different bills. With the madness that went on this past weekend, everything got put into about 2 different bills. And the budget did not officially get started being debated upon until like 11:37 p.m. and they were supposed to have it done at midnight. It didn't get done by midnight, as we all know. It finally got approved by about 2:30 in the morning in the Senate side. So that 11:59 is probably one of the longer 11:59s we had, but it was quickly becoming obvious that they weren't adjourning officially on May 31st. Even when we went into May 32nd, also known as June 1st, we do know that they're going to be coming back. There's some outstanding issues specifically on energy reforms specifically for issues surrounding Exelon that the General Assembly is wanting to address before they officially adjourn for the spring session. So we will have some June session days coming up over the next couple of weeks. It sounds like today it may be in the next 2 weeks that they may be back, but we don't know anything official yet. So there is still some time for additional legislative actions to happen. So we'll be keeping an eye on that and having our some movement in some of that our agenda items hopefully as well. But we look at a $42 billion budget. $42 billion should make most of us sick to our stomachs when we think about that. That's what the size of our state budget is. It wasn't just not even 5 years ago that we crossed the $30 billion line. So our budget in the state has significantly ballooned in the last decade. So it's something that we need to continue to look at. A lot of these monies that were in the budget were from some of the federal emergency funds. And so eventually we will have to pay some of this back, which means some of these programs that may have been expanded or initialized, they're going to have to find a way of paying for it. And everyone hang on to your wallet. I know Laura's got a question before I go into the budget. Go ahead, Laura.
Hey, 1.9 million for the Board of Pharmacy? Is that? I don't think I've ever thought about how much it costs. Is that an average number?
Yes, and most of that money is from our licensing fees. So it's not like they got any additional money. It's the money that's already there from our licensing fee.
Before my Sicilian side take over, right. Thank you for clarifying that. Okay.
Right. Which it's always important that we look at this number, and this, in addition to the cap funds, which I'm glad was sustained for another year at 10 million. The Board of Pharmacy is the next one I go to, because if that fund gets swept, then the Board of Pharmacy doesn't have money. And so we got to make sure that we're there to help protect the department, make sure that the board's got sufficient funding, because that has been a tactic in years past where there's been fund transfers and fund sweeps. And we've had a board, I mean, think about a couple years ago, the Board of Medicine was bankrupt and was broken. And it took a significant reforming and a huge license fee increase on the Board of Medicine side, the physicians, to help reestablish the Board of Medicine, because it had just been completely decimated by funds transfers over the years. But we see that $10 million for the Critical Access Fund, the about $4 million for the Poison Control Center is still there. And I do put that one in there because there's a number of pharmacists that help administer that program. And then from the General Professions Fund, there is, from DFPR, there is particular allocations to the state schools of pharmacy, and all those are in its traditional amounts. So we didn't gain any additional monetary advantage in this budget, but everything stayed the same. So that's good. That I'd rather stay status quo than lose anything. But one thing that did get put into the budget in the middle of about 800 pages was some language that Illinois Retail Merchants was helping support. And and this comes from conversations that pharmacy stakeholders, mainly IRMA, ICHP, and IPHA, have been discussing on trying to find a way of being able to help preserve some of the COVID expansions. And we were trying to figure out the perfect vehicle. Well, putting it into the budget implementation can be a perfect vehicle with everything else that's in there. So this does preserve once everything is rolled back. So this doesn't change anything yet, because the federal exemptions right now override this. We will, once things are back to normal, be able to immunize for any vaccine ages 7 and up. The big part of this paragraph, in addition to that big change for the 7, is that it also states now in the Pharmacy Practice Act, once the budget is signed, that Medicaid and other payers for vaccines ordered and administered shall cover reimbursement at no less the rate than what's administered by a physician. So all this language that's in here is from what will be in the act. So again, a second place for us to add additional items in the future. And this one is at the same rate as the physician. So this is something that, trying to find ways that we can help preserve these. These are going to be built on additional conversations going forward. The legislative committee and has this, was discussing, some of the additional strategies that were as part of this, and ways that we'll be looking at trying to have continued conversations over the coming months. But I did want to kind of give everyone kind of a preview of what has happened, and everything that we talked about in those slides is everything that happened this weekend. So that's just to let you know how many pharmacy and healthcare related bills were happening just this past weekend. Your board of directors and the legislative committee received a report today that showed that IPHA, of the 330 bills that we were monitoring, 63 got sent to the governor. And one thing that's really good on all the bills that we have been monitoring and advocating for or against or neutral, nothing went to the governor's desk that we opposed. And so our advocacy efforts were significant this year. And we didn't hit everything on our checklist by far. I mean, we still have a lot of issues that we still got to overcome with PBMs, but we made significant advocacy movement in a lot of other arenas in looking at advancing pharmacy practice. So, Dennis, I saw that. I just now noticed that your hand's up. I'm so sorry. Go ahead and unmute your line. It's still showing unmute on this side, Dennis. Yeah, I'll do an ask to unmute and you can just hit yes. There you go.
Now?
Here you go. We can hear you.
All right, with most legislative pieces, there's always two other things needed, and that is one, where's the funding going to come from to support that language? And then two, who's going to do the enforcement?
For which language?
The last item you talked about.
The funding, well, that's going to be for Medicaid to figure that part out. I mean, they've got significant dollars that are already appropriated for vaccinations, and this will just make sure that they've got to cover us. And hopefully, as we continue on a federal level to work to get rid of, now that pharmacy has been pulled away from being required to be part of VFC, we're hoping that will become a permanent exemption from the CDC, so that we can continue to do that. Hang on one quick second here. So, but no, Dennis, it's something that, depending if we continue increasing vaccination rates, it's something that should be a good problem for Medicaid to have, because they still need to prove that outcomes are more important than budget lines. And so, but they have a problem with that at times. So I'd like them to have the problem that they've got to increase funding for immunization rates.
Because, along that same line, though, because we're allowing technicians now to be part of the package, there's already been grumbling about them that we're doing more now, we need more money. So the tech's going to be looking for salary increases. And obviously that's going to go who knows where.
Well, that's why we got to start working for reimbursement reform. And that's why it's like everyone needs to get on board. I know a lot of people continue to think, and I'll be very direct about this, that PBM is an independent problem. And that idea and thinking needs to go away with a lot of other outdated thinking. PBM, the damage that PBMs are doing to the pharmacy is a all pharmacy problem.
Yes.
It doesn't matter what segment of pharmacy, whether you're in academia, health system, long-term care, chain, or independent, PBMs are a threat to your profession. And we have to continue to work on reimbursement reform, and that has to come, because if not, we're already, we've all seen the damage it's done, and we need to be setting up, as we stated earlier, technicians for a higher advanced career path, and that will mean that they'll need to be paid more. And because we're going to be putting more risk under them, we're going to be putting more liability under them, and we're going to be putting a lot more responsibility under them, and so they have to be compensated for that as well. You bring up some very valid issues there, Dennis.
Well, and again, now you're going along that line with the technicians is
Mhm.
what's the how we guarantee the quality of training now in those new areas?
Well, it's like with immunizations, it's required that they complete one of the approved accredited training programs, like the IPhA program. So they have to, in any additional tasks that they're delegated to, the pharmacy should be documenting how they were trained. And there will be, there may be additional training programs in other areas as we go forward.
Okay. All right, thank you.
No problem. Good question. Any other questions or comments? I know we're a little bit over our time, and as always, I don't know why we try to say an hour. It never is an hour. But I always want to make sure that you guys are well informed of what's going on, and we've just had a lot go on in the last 5 days. So I just want to make sure that we did review some of the highlights of that. As two reminders, one, we have Travel Health coming up on June 9th and 10th. So please do sign up for that. We've actually got our biggest class so far for Travel Health. I'm very excited to take those individuals through that course coming up. So we did split that up over 2 nights. It's only 2 hours each night. So please do take advantage of that. This is something you can add on as a service to those of you who have immunization care programs. You don't need to be in a metropolitan area to have a successful travel health program. Everyone travels. There's a lot of corporations in your communities that need access to travel health consultations, and it's more than about vaccines. So it is really about taking another step forward in a billable service. So do consider that as an option. And then most importantly of the certificate programs that we've got coming up, we got June 19th. It's a Saturday. We have the IPhA cardiovascular certificate. If you don't take this program, I'm going to be very disappointed, because it is part of a grant initiative. So therefore it is offered at a significant discount. It's only $59. We need pharmacists taking this program to help with the initiatives that we're working on with the state. And I think, Starlin, please correct me if I'm wrong. Ginny, you're teaching that one on that Saturday, correct? Right. So you couldn't ask for better faculty for that program. So please do take that initiative. I know it's a holiday weekend, but take advantage of a significant $300+ discount on that program. And it comes with almost 22 hours of CE. So it is a significant chunk. I think it's actually the largest CE component of the programs besides diabetes. So you can get a lot of your CE out and be able to assist, and especially any of you who have taken the previous lipid management program a number of years ago, you definitely need to take this again, because this is the evolution of that program with a heck of a lot more in it, and I think a lot better program all around too. Darlene, anything you want to add in on that?
If you're part of any of our DPP 1815 grant, you really need to be part of this, because the focus is on stroke prevention, blood pressure control, and cholesterol control. So, and it's virtual. So we don't know how much longer the virtual processes are going to last. So take advantage of not having to travel, as well as the $59 bargain. If we don't put people in these programs who are going to get money cut from our grant.
Right. Yeah, because right now I'm working on next year's grant, and I'm not sure if it's going to be focused on these education programs at this point. So take advantage of it. I know everyone's like, well, I'll take it the next time it comes around. Well, the next time it comes around, it'll be $350+. So I know which one I would choose. So. All right, everyone. Any last minute questions or comments?
Hey, Jenny, do you want to tell them what we voted on today at the Conference in Education?
You're talking about the theme for the annual conference? Remind me what it is, because it's a little different than what we had talked about. Shoot. You have it?
I think I remember it, Jenny.
Okay.
Wasn't it refresh? Something reignite?
The last word is reignite.
Refresh?
Hold on, I've got it here somewhere.
Something with an R
There's
and
3
reignite.
R's.
Reconnect.
The 3
Reconnect.
R
Correct. Refresh.
Refresh, reconnect, reignite.
This is
Refresh, refocus, reignite.
No, we got
Refocus.
There were a lot of different versions of R words that went out. That's why there's a little confusion here. Reignite, I think, is the most important piece of that. I think we all need it.
You're welcome.
that was amazing.
Reconnecting is super important too, I think, this year. And by reconnecting, we're going to reignite.
That's
I
right.
was remembering, so.
yeah.
And
I
remember,
put away my notes.
and remember, conference is in October this year, so we're a little bit later than we normally are. Any other last minute questions or comments?
And we need everybody to stay in the hotel so we don't have to give back money. Y'all
Right.
need to know that if we don't make head count in the hotels, they take money away from us.
Well, they don't take money away from us. They put money on top of it. It's a charge.
Yeah, especially
Well, there you
Saturday.
go.
Everybody stays Saturday night.
Yes.
finally old enough to have my own room.
You're finally old enough to have your own room? Okay. And remember, it's October 21st through the 24th, and in St. Louis at Hilton at the ballpark.
Can't wait. I got to party twice as much to make up for Dr. Sandusky from last year.
Yep.
So that means like
Thursday night is
We're-
we're gonna
Our
party with
entertainment is Nelly this year.
Oh, come on.
You can find me in St. Louis.
I thought
With or without the Band-Aid.
we're in Pontiac.
Well, the Band-Aid's brought to you by Johnson & Johnson, so it could be a vaccine event.
That'll be fun. We should do that.
Get Nelly?
Oh,
He'll be too busy in New Berlin at the Sangamon County Fair.
right.
That's true. No, not
Well,
yeah,
that's all right, because we'll all be going across the street to Busch Stadium because there will be October baseball, and we all know what that
we hope.
means.
My grandkids and daughter are watching the Dodgers play the Cardinals tonight in LA.
Well, that's good.
Finally get
All
some,
right. Go ahead, Dave. Sorry.
they need to get some pitching. Come on, bring them up. Trey, do something.
All right, everyone. We'll remember again, 1st of July, first Wednesday in July will be our part 2. And we'll see everybody in a month. And everyone have a great evening.
Night, everyone. Thank you.
Bye.
Good night.
Bye.